hello to our wonderful Brainstorms audience. We so appreciate you every single month helping us work through topics that help our veterans, primarily from the global war on terror, but from any conflict, who struggle with traumatic brain injury and all of the comorbidities that go with it. So here we are. We're getting ready in this beautiful Sycamore Studios, our home studio in Plain City, Ohio, brought to you by that generous grant from the Fred and June McMurray Foundation in Los Angeles. And we thank them every month as well for being able to come to you. We are getting ready to start the holidays. And I don't know about everybody else, but I came from a very interesting family. You know, they usually say that I put the fun in dysfunctional, but we definitely have issues that happen around the holidays, particularly now when we have kind of a world in chaos, definitely a country that seems to be going in a divisive direction. We want to keep everybody together because nothing really bothers anyone in the civilian world as much as the divisiveness in the country as a veteran who lost a friend or two or 30 in a conflict to keep us all together. So I think we need to keep that in mind too. I am so blessed today to have a wonderful young practitioner who's got just a vision that offsets with mine, a lot of energy, and is exploring new ways to help people, particularly with disabilities, deal with the struggles in our world. So without anything keeping us from introducing her, here is Dr. Lauren Khazem from The Ohio State University, and I'll let her tell you a little bit about herself. Thank you so much, Dr. Khazem, for coming today.
Well, thank you so much for having me. I'm excited to be here. So I am a research assistant professor in the Department of Psychiatry and Behavioral Health at The Ohio State University.
Okay.
I'm also a licensed clinical psychologist. From a research perspective, my work does focus on making sure our suicide prevention interventions that work better.
Yeah.
So ways of adapting them for populations who may not otherwise be able to receive these treatments.
Gotcha.
Also adapting them in ways to make them more accessible. So the populations I particularly work with are veterans, military personnel, and people with disabilities. And certainly there's sometimes, or a lot of times, overlap between these communities.
You know, I find that to be fascinating because definitely our veterans fit in that category of so many of them have what we call that invisible wound of traumatic brain injury, which doesn't have any outward disability. I mean, these are young, strong, competent people that I think it sometimes takes people off guard if there's something that kind of makes them either depressed or makes them angry, that people are wondering why that would be. So tell me a little bit about what got you started in this particular subset, which is a very difficult patient population to deal with.
I started this work as an undergraduate student,
Okay.
as a research assistant. I was given the opportunity to conduct my own research study on basically anything I wanted or a particular topic. And I expected that there would be a lot of information out there about suicide risk in the disability community.
Right.
Unfortunately, when I did my literature search, I came up pretty short.
Really.
There was hardly any research out there on this community besides that suicide risk is higher, but we don't know why.
Right.
And there wasn't anything out there in terms of what we could do about it or
Gotcha.
treatment. So that's how I started down this path. And I've been doing this work close to 15 years now.
Oh, bless your heart. So let me ask you this. Was there anything that kind of made you explore that? 'Cause you're very young still,
Yeah.
okay? And you were even younger back then. What was there anything either in your personal life or what you saw around you that said, this is a population I'd like to serve? Could you tell me just a little bit about that?
Sure. So I'm legally blind, actually.
Okay.
So part of um, my kind of thoughts about this work came about when I was visiting a conference
Okay.
for people who are blind, low vision. And I noticed that there was a sense of community here that
Okay.
wasn't necessarily present, like in the real world, quote
Oh,
unquote.
yeah. Yeah.
So I wondered how that impacted people with disabilities, particularly those maybe who have less vision than I do
Right.
or who have different types of disabilities.
Right.
Do we see impacts of ableism or just living in a world that is inaccessible to you um, on suicide risk?
I understand. I mean, that's usually there's some kind of an event, either
Sure.
yourself or somebody near you that kind of triggers that. I know that I was I loved working with patients who had brain injuries when I was a resident and in training at The Ohio State University in physical medicine. But it wasn't until I had my own, let me tell you, that it was a whole new story. I mean, I was thinking, there are different things that I said to patients that I go, I'm not even sure that should have applied because it didn't apply to me when I was in the same situation. And I think that was what I call my boot camp. That was, kind of divine providence training me for what I would do in a few years, which is be able to identify with, I'm not courageous. I didn't go to war. I mean, I literally was a klutz, hit my head against a brick wall, which I think is a really interesting metaphor, and really happened. And it changed my perspective as well. And what I realized is, to go from somebody who's very able-bodied, like our military,
Mhm.
to a blast injury or a rocket-propelled grenade, so anything, to suddenly having disabilities you can't even mention. You're not hearing the same, you're not seeing the same, you're not
Mhm.
balanced the same. It really does throw you off, don't you think?
Absolutely. And that's pretty consistent with what my research finds too, is among people with disabilities, various types really. We see that this belief about being a burden to other people is particularly present when we have these like shifts in our like roles in life,
Yes.
certainly, but particularly for people with disabilities, when we're internalizing these beliefs or we get told ways we're a burden or we start having differences in terms of what we can do or what we need help with, these beliefs start to develop and they do influence thoughts of suicide or they do tend to lead to them.
Well, I know we talked on the phone, and I had read Dr. Joyner from
Yes.
down in Georgia,
Yeah.
Why People Die by Suicide. And I thought
Hmm.
it was amazing when he talked about our veterans, our
Hmm.
military members. He said that there were three main things, and please expand on that because I'm sure your research has expanded since then. But, you must have the desire, you
Hmm.
must have the means, and definitely our military members have the means.
Right.
But the third and the most important was exactly what you just said, that
Hmm.
you now see yourself as a burden.
Hmm.
And that's what I've noticed with the veterans on just the discussions I've had over suicide threats and even suicide, ideations or even, a suicide attempt
Hmm.
that luckily did not work and the person was able to come back. You have to be able to say, okay, right now this is where you are, but maybe here's what you can do. How do you approach that when somebody comes to you and they really feel like they're a burden to their family, to their society? Tell me just a little bit about what you've learned and how you work with that.
Of course. So I would say that's actually the number one belief that I work
Really?
with people with disabilities in particular, veterans as well, but particularly those who are disabled in some way. And the thing about this belief is that it's tricky because people are constantly bombarded with information, whether that be from society, the media, thinking about even the movies that are out
Yes,
there and how disability is portrayed. A lot of times it's the hero or the burden.
very true.
So,
And it's
yeah.
never really in between, is it?
No, it's not.
Yeah.
So these beliefs tend to be internalized. And when I discuss these beliefs with patients, they're very quick to come up with these types of examples.
Okay.
I've had patients tell me, well, my doctor says I'm a burden on the system.
Oh,
Specifically,
really?
yes.
Oh,
So
wow.
we have to discuss like these beliefs and pick them apart and say, just because society says it's true or provider or someone told you this, doesn't make it true. Has society um, discriminated against, had negative views about other people, like undeservedly?
Right.
And the answer is yes.
Yeah.
So we discuss how this applies to them. And a lot of times when people have the belief, I'm a burden, what they're really saying is, I am just a burden. I am nothing but a burden.
Oh, very good. Yeah, that's a
So,
very good, yeah,
yeah, so they're
observation.
implying this, right? These
Mhm.
sorts of all or nothing terms,
Yes.
black or white thinking, so to speak.
Okay.
So we discuss ways in their lives that they do contribute, whether it be in their relationships or community, providing some other sources of support, even if it's different than what it used to be. While acknowledging that, yes, we still need help in some areas.
Yes.
We don't want to put on rose colored glasses and take this belief to the extreme, the other direction.
Okay.
But we want to acknowledge what is true and valid, but also what are we missing
Yeah.
when we tell ourselves these things?
it was interesting because more than a few of the vets I've spoken to, will talk to me about,
Mhm,
well, I really wanted to come home and take care of my family. And,
mhm.
with traumatic brain injury, which is our area and what Brainstorms is all
Sure.
about, you have so many things that you can't do right away. You can't process
Mhm,
as fast. Your memory isn't as fast. Trying to get employment or even education to be able to remember the materials and how to
mhm,
do the job is difficult. Now, we can work with them and help bring that brain back to a new normal state. But in the meantime, they feel like they're such a
mhm,
burden to their family. And so many times they would talk about a burden to their spouse, whether they're male or female. They're talking about a burden
mhm.
to their spouse. And I said, well, have you talked to them about that? Every single time, I don't want to burden them with that conversation. So, what do you say? Do you get families involved in this particular process?
Mhm.
And how do you do that?
So first, I always place the patient I work with their autonomy first. So if they
Okay.
don't want to work with a family member,
Okay.
absolutely not. That's okay. But work on other parts of that belief being a burden.
Okay.
So I'll ask if has your family said anything to you that indicates that you're a burden?
Right.
Have they done anything? Or sometimes I'll be quite sneaky and I'll just simply ask point blank, like, tell me about the things that you do in your house
Oh, very
or
good.
with your family to
Right.
contribute. Tell me about your relationships. So people are already telling, like, giving me evidence
Y-
for ways that they're not a burden. And then we discuss how that doesn't quite fit with the belief that they have.
I see.
So we can get some movement there. And if ideally, if we could get family members involved
Yes.
further down the line, that's fantastic. But if someone absolutely does not want that, then I'll respect that and we can continue to do the individual work.
Yeah, that's very interesting, and giving it time. That's what it's really difficult because again, I'm primarily dealing in the space with a younger population, and
Mm-hmm.
everything is time sensitive. And they
Right.
come back from their service, and they're already way behind their peers as they see it. They're years behind. They don't have the education many of the times.
Mm-hmm.
They don't know what they're going to do in employment, and it's very difficult to jump into that perfect. We have so many what we call the perfect family, which I try to dispel immediately, but they don't have the stable job, the two
Mm-hmm.
kids, the great relationship with the wife, the car in the garage,
Mm-hmm.
those sort of things. So when somebody, for instance, comes to see you as a veteran, where in that process do you normally see them? Do you see them when they first come back or when they're already feeling like they're failing? Oh, tell me just a little bit about that, how they get to you.
So usually folks get to me when they are having thoughts of suicide or they've recently attempted suicide.
I see.
Or I also work with individuals who have PTSD as well.
Yes.
So I work with both those populations. Certainly there's an overlap.
Okay.
But from the suicide space, people will come see me when they're having thoughts of suicide. They're struggling with that. They've had recent attempts, we'll say within the past month.
I gotcha.
And so we can work from that perspective of I'm really struggling. I'm finding it difficult to find reasons to live, and I want to do something about it.
Oh, that's wonderful if they acknowledge that
Hmm.
and that they come to you and somebody who is, to me, I've had so many people say, well, I'm really worried about my buddy and he's talking like this. What I do? And I go, isn't listening important?
Yes. Yes,
Tell us a little bit
absolutely.
about that because we're coming up on the holidays. And here's what
Sure.
I'm thinking. I was talking to you on the phone when we first met,
Hmm.
and our Resurrecting Life Foundation is not a crisis intervention.
Hmm.
We are here to kind of bridge that civilian military gap and help our veterans obtain health care, education, and employment within the community. But in that space, I don't know how people get a hold of my cell phone number, but they do. And I know, and why I'm so thankful to you and Dr. Baker, who will be coming on
Hmm.
the podcast next month, just how important the holidays are because you're bombarded with, let's go to the movies, let's go to the Hallmark Channel, and
Hmm.
the perfect rom-com Christmas where
Right.
everything works out. That's not the real world. And suddenly I think they're kind of faced to that. So
Hmm.
my question to you is, what do you kind of tell family members when you see them to both identify with this problem and kind of move them into a better space? How is that even done in the real world?
in the real world, when someone ideally comes to you and says, I'm struggling with thoughts of suicide, whether it be a friend, a family member, you're absolutely right that sitting and listening to them and not trying to jump in and just fix everything
Yeah.
is critical.
Yeah.
A lot of times people want to be heard. And people who tend to have thoughts of suicide or maybe even a disability, TBI,
Yes.
especially, you've had
Right.
people want to jump in and help.
Right.
So I resist that impulse and let the person speak,
Hmm.
really validate what they're going through is hard
Right.
and encourage them to, seek support and services. So can't expect every layperson to know exactly how to respond to a suicide crisis or
Right.
to
Right.
do the right intervention at the right time.
Right.
But we can direct people to places where those services are available, a lot of times free or low cost.
That's very helpful. I know we were talking about the increased incidence of traumatic brain injury
Mhm.
and suicide. And again, I know that things have changed over the course of the last 10 years, but in the veteran space, the people who I've used as my mentors, of which the Ohio State University Department of Psychiatry,
Mhm.
both Holly Caston, who kind of helped start the S.T.R.I.V.E program that we'll be talking about, um, as well as Dr. John Campo, who used to be there. If it weren't for those two members of the OSU Department of Psychiatry, I don't know how I would have worked through this to begin with, because I was an ER physician and a rehab physician by training, and it's very different what you do versus the long haul. And what we had learned is that somebody with a traumatic brain injury was about 8 times more likely to contemplate taking their own
Mhm.
life. And if you had a military member now, the latest statistics that I read say it's almost twice that number. Again, because they have means, that
Mhm.
the means has been taught to them well. So maybe 16 times, which is really
Mhm.
large. And then there is a psychiatrist who has dealt primarily in the space of the young military member, whom we now know oftentimes the brain is kept in a state of adolescence, both hormonally and psychologically in that state. And his big problem was the use of major psychotropics that were going on early on
Mhm.
when our vets came back and joined the VA system. And he thought then the risk went up to almost 32 times. So they are definitely at a disadvantage. And I
Mhm.
know in your population, you said that people with disabilities are more likely to hit there too. And what do you notice in your population with both the suicide ideations and the follow throughs?
Mhm. I would say there's a lot of similarities between the veteran population and people with disabilities. Um, Again, there's overlap there,
Yes.
but certainly the idea of means is still critically important,
Yes.
both populations.
Yes.
So that is an area I think where a lot of work needs to be done, not necessarily like complete restriction, taking anything away from anyone,
Right.
but
Right.
what are ways we can make our environment safer, even if it's just one step,
I see.
to buy yourself more time
Yes.
um, in these moments of crises?
So we're getting ready for everybody sitting down at the Thanksgiving table.
Hmm.
Now, we will also realize there's a whole group of people who
Hmm.
will either be homeless on Thanksgiving or not sitting down at anybody's table, reminiscing about loss,
Hmm.
which I think is, in my experience, one of the perpetrators, that thoughts of loss, either loss of friends, loss of family, or loss of their own sense of self. What do you suggest to families who may have a family member with a disability, whether it be a veteran, or who may be sitting down with them? That how do you kind of avoid things that may otherwise maybe make them feel worse, or include them without going
Hmm.
overboard? Oh, Joe's here, yay! Let's all clap for Joe.
Yeah,
That sometimes works in the opposite direction as well.
right.
So, what would you give? What advice would you give to our audience who are going to be, at the table with folks like this?
So that's a great question. When we think about the holidays, it's certainly stressful for anyone. And if someone has like a newly acquired disability
Oh,
or is really not responding to their disability well,
okay.
uh, keeping in mind that we also want to treat people with disabilities, our family members, the same as everyone else, while
Right.
keeping in mind they might also have new accessibility needs.
I see. Right. That's very
Mhm.
good. Okay.
Mhm.
So if they need help, for instance, even getting to the table, to know that ahead of time.
Yes.
a-
Yeah.
a-
Just keeping in mind like you're is there even space for them
Yes.
before they show up at your door? Is there a pathway to the table, for
Oh,
instance?
that's
Is the
something
lighting in the
simple,
house
but still
Yeah,
very important.
sure. Is the lighting in the house too bright? I mean, if all else fails and you really don't know what to do, you can certainly call the person beforehand and ask, do they have any accessibility needs?
Right, right.
So that way it's seamlessly taken care of before the person gets there. And there's no scrambling around making a big deal
Oh,
out
that's
of
a
what's
very
needed.
important point.
Mhm.
And we can even go online too. I mean, I'm sure that there
Absolutely.
are some things online, if somebody's coming over, wheelchair versus
Yes,
crutches versus, what things like the rugs. I know those slippery rugs on the floor,
absolutely.
please pick those up. That's a very good idea. So first, make it a welcome
Mhm,
environment that they don't have to stop and rearrange everything
mhm,
or have people feel burdened to rearrange things for them.
mhm.
Okay, so that's step one before they even arrive.
Absolutely.
Okay, okay. What about their sitting at the
Mhm,
table now? Are there certain things right now? I think the country at large needs to just chill on some of the
mhm.
conversations that we know are going to be heated,
Sure.
and the political has been difficult for the last, 8 years. It's going to be difficult going forward because okay, this is terrible to say to somebody in, your particular, because you're such an expert in psychologically, defective people, which I think I was as a teenager. And I look at our nation right now as me as a
Mhm,
teenager. We're kind of a young country. We went through our growing pains when we were
mhm.
young, and there were a lot of things that happened at the beginning that we don't even read in history anymore. I mean, there were times when in Congress there were out and out fights. I mean, literally brawls, fights
Right.
with weapons, even. So we need to realize that. I think maybe we're kind of in the teenagers, and if tell some of my vets, just handle it as such, or their families, handle it as such. I don't know how to take care of teenagers. I don't have
Mhm,
children. So what kind of advice would you give for if somebody starts getting,
mhm.
heated in a discussion? What are some segues to move it away? Because I don't know those very well.
Yeah, absolutely. I generally don't recommend talking about politics at the Thanksgiving table for that exact reason,
Yes.
but things happen.
Right.
So I tell people that I work with, let's plan to cope ahead in case this does happen because we can't control what other people are going to do or say,
Right.
but let's plan for it in case something like this does happen.
Yes.
Tell people you know your family best, you
Yes.
know probably what's going to come up. So let's make a plan for in case it does. In dialectical behavioral therapy, it's called coping ahead.
Oh,
Um,
that's a wonderful phrase. That's really good.
mhm,
Okay. So if you're the hostess or the
mhm,
host
mhm,
and you have these people come, what sort of things would you remind them of? Because they're really going to be the person, you know,
mhm,
even if there's other vocal family members, it is their homestead.
mhm,
And I found the person that has it can make the rules.
mhm.
What
Sure.
sort of things do you tell them to say or do?
I'm not sure if I have one off the top of my head, like a very specific situation.
Okay.
It's
Okay.
usually
That's fine.
like when I work with patients, it's like somebody come back and like Thanksgiving went terrible. Like my mom yelled at me, or there's something to that extent. But like,
That's really good.
okay,
That's really good. Let's talk
sure,
about that. Like,
okay,
we've talked about the coping mechanisms before,
mhm,
but sometimes things just
mhm,
happen and
mhm.
people get carried away. And
Yep, and that's why we have the plan beforehand. Is
yes,
so in case that happens, they know what to. They've developed a plan, like whether that is to go outside and take a deep breath, or to call a friend or like play like watch videos on your phone for a few minutes.
oh, that's
That's
a very
fine.
good one.
Yeah. So I tend to focus less on, what like the host wouldn't
Okay,
do, but more like what can the patient do?
okay,
Because at the
let's
end of
go
the
there.
day,
Yes,
yeah,
please.
sure.
So, some of those strategies, let's kind of pick those apart. First of all, I really like that step away from the table.
Hmm.
I've stepped away from the table, and my family has asked me to step away from the table. So, that's an easy thing for me. I usually grab a dessert on my way out, that sort of
Sure.
thing. But I like that idea. Going outside, going to nature, going
Hmm.
to where you can. So those are two really good ideas.
Hmm.
When you say call a friend in video, let's expand on that just a
Hmm.
little bit. I would love to say when you say watch a video, do you have videos in mind or their favorite video or music videos? What sort of things advice do you give your
Sure.
patients?
So when patients plan to cope ahead,
Yes.
they can pick any video they want as long as it will be helpful to the situation. So,
Okay.
for instance, if they are feeling really aggravated,
Yes.
sitting and watching like a music video like their favorite death metal band probably isn't going to be the most effective in
Right.
that moment. So we pick something else that might calm them down, might induce like the opposite emotion to what they're experiencing.
Yes.
So if they're feeling sad, watch stand up for a few minutes.
Oh, well, right.
I have one patient who loves watching, videos of like her favorite animals. Those are all appropriate to do in the moment, and they're quick, and then you can bring yourself back to the situation
I
later.
really love the idea about the comedian. I find comedians to be very helpful. They're very intelligent people who show us the kind of dark side and then bring
Mhm.
us into the lighter side about it. And just kind of an aside, during the pandemic, we had a group of veterans who had trained together at Fort Campbell, had
Mhm.
served together in theater, and they come back and were scattered kind of between Virginia and Tennessee, Georgia, Ohio, New York. I mean, and we brought them all together once a week for comedy night. And I will tell you, the beginning, while I was watching and I had a few of our donors, I said, guys, first of all, I don't understand a lot of what you're saying. And let's kind of keep this more PG 18 at the very worst, not X-rated show. But it was up to them. I never tell a veteran what they can or cannot say because they're the only people I know who volunteer their lives for free speech. But I do think that's an idea. And one of the things that maybe I'll do with you or with your staff is to get some videos up on our website so they could go, just to the website, click, and there will be like I love Nate Bargatze, who is just down
Yes.
to earth about so many different things. There are a couple really good comedians in the Filipino space where we've have a lot of minorities who serve, including the Filipino population, our Native American population, the Hispanic population. So I will do that. I'll probably clear it with your office and make sure I've got the right thing. But I do like that idea. That's really very helpful. Most of my little vets that I talk to, I don't know why I call them little. They're all, but they're much younger than me. I should say my younger population just amazes me with their music because things like meditation, they're not really into listen. I love listening to the sounds of the sea and birds, but not necessarily. So I think that's really very good. And staying away from heavy metal and some rap things that tend to, you don't want to stir up feelings of violence or anger, when you're already wondering why we had that conversation at Thanksgiving dinner, right?
Exactly. So we want to have people listen to whatever or engage in if they're like listening to video,
Yes.
listening to music, watching videos, whatever's going to work for them. At the end of the day, I don't really care so much what it is as
Yes.
long as it is being effective.
Right, right. That we'll give them some options for your because
Mhm.
you've worked in that space to see that. You said about calling a friend. Could we go into that just a bit? So I would love your advice for both your patient calling a friend and just a little bit for the friend taking the call on the other side, if you don't mind.
Absolutely. Part of planning ahead is having people that we can call when we're feeling badly. So these aren't necessarily people we need to call and say, hey, I'm thinking of killing myself,
Yeah.
unless they want to and they feel like their friend is able to handle that.
Uh-huh.
But these are just people that we can call and talk to, or just listening to their voice
Oh,
or
true.
receiving a text from them lifts our spirits.
Yes.
So I tell patients people generally like to talk about themselves. So just saying, Happy Thanksgiving, how are you doing? And getting them talking
Oh, yes.
tends to lift their moods. So part of that plan of coping ahead for these types of situations is having a list of people we could call for feeling badly if we want to hear someone's voice, get our
Right.
spirits lifted.
That's very, very helpful. And I know you and I spoke briefly about the 988 number and the
Right.
emergency numbers. If you could explain to our audience too, because you know that space so much better than I
Mhm.
do, I would love what kind of advice you can give people on
Yeah,
that as well.
sure. Sometimes people don't have anyone they can contact or call. That's okay. Sometimes they call people, they're not picking up the phone. They, um, you know, didn't receive the support they were hoping
Oh,
for.
yes.
So there are professional services available. 988 is one of those,
Okay.
where the National Lifeline, where people may just call for free, confidential space to have someone listen to them and point them in the direction of services.
Gotcha. Here's what I find to be so difficult.
Mhm.
Okay,
Mhm.
just from my standpoint. Um, Thanksgiving is always a Thursday.
Mhm.
Thursday, Friday, Saturday, Sunday, it's not till Monday.
Mhm.
So, if you get a call Wednesday night
Mhm.
or Thursday, how do you get the person to a safe space? Other than an emergency room,
Mhm.
I'm not sure exactly where they go. Do you have any ideas about how they could get to a space for evaluation or treatment, or even just to meet a counselor like yourself
Mhm.
who's on call for that
Mhm.
space? Do you have any words of wisdom for us there?
Sure. These are situations which I would encourage someone to call 988. These are people who are trained to help de escalate, to
Yes.
calm the person down, to plan, to keep the person safe, to help them use coping strategies.
Yes.
You're right that sometimes we can't get someone to a safe space, or maybe they're not even in an area that has something close by.
Yes.
So this is exactly the situations where these lines are available for, or like the Veterans Crisis Line.
Yes. And how long can those calls go? Can you be on that call for a period of de-escalation, which may be
Mm.
minutes to an
Mhm.
hour? I mean, is that a possibility, or do they then connect you to somebody who can do that? So if somebody calls 988 and there's a big volume
Mhm.
and maybe they can't get as much time, they should feel free to call back though, however, right?
Absolutely. Yeah.
Okay, that.
And there's also online like chat based options as
Oh,
well.
there is?
There are, yeah.
Oh, that would be a very good option, I think, for some folks, because it seems to me that so many of the veterans are just masters of the internet.
Sure, sure.
Whenever I need to really find something, I'll email one of my
Mhm.
vets. Say, can you find me any of
Mhm.
the following
Mhm.
information? And they're very helpful for
Yeah.
that. How would veterans get in touch, for our veterans in Central Ohio in particular, with the Ohio State University? How do we go about getting in touch with you? So, for instance, we have people who are going to be hearing this say, I'd really like to meet Dr. Khazem. I'd really like to know what her team is doing. How would they reach you? And we will also be putting that on the website. But how
Mhm.
is the best way to do that?
So the wonderful thing about Strive is that we are actually able to serve veterans and military personnel across the country.
So let's talk about what
Sure.
is Strive.
Yeah, sure.
That's really good to know.
Sure. Strive is the Suicide and Trauma Reduction Initiative. So
Okay.
we're housed in the Department of Psychiatry and Behavioral Health at the Ohio State University Wexner Medical Center.
Okay.
And we offer evidence based interventions, or usually non medication or psychotherapy
Okay.
interventions for PTSD, as well as suicide prevention.
Wonderful. And that's been around.
Mhm.
I think Holly Caston, when I originally was getting started with this
Mhm.
foundation in like 2010, 2012 space, was really working on that at the time. So it's been around for how long, though? I don't really know.
So Strive has been at OSU since 2020. We
Okay.
originally housed in the University of Utah, and our team moved here to grow and expand the work that we do.
Okay.
So we are newer, but within that time, we have grown quite significantly. And we are able to offer telehealth services as
Oh,
well as in
really?
person services as well.
Oh,
So
that's
that's how
wonderful.
we're able to see people all across the country.
Oh, that is wonderful. And we will put those links there as well.
Wonderful.
I actually heard about you and what all you were doing, and Dr. Craig Bryant
Mhm.
from the folks at Face the Fight.
Oh,
And
great.
they
Yes.
gave a, a seminar that we'll be talking about on segment two, which is having that, response plan,
Mhm.
in place and how to
Yes.
do that. And I know it was kind of your team that invented that,
Mhm.
engineered that,
Mhm.
whatever we want to say, but it was very, very good. And we'll be talking about that as well. So can they contact you then via
Mhm.
email and get somebody to chat with, or?
So there is a link on the site to where you would fill out a questionnaire
Okay.
to basically see if you're eligible for any of our programs. And because a lot of these are housed under the umbrella of research, they're
Right.
free of charge.
Oh, that is wonderful. And I've got to say to all of our veterans and their families, the research that you have been doing is
Mhm.
absolutely phenomenal. And I believe that it gives our vets a mission as well.
Mhm.
What you're doing. I've had so many veterans say, Doc, I don't need that service. I said, but if you know somebody who does, you
Mhm.
know, if you think, I said, first of all, you've had 8 blast injuries, so it would be good for you
Mhm.
to be seen by somebody, and let's just see if there's something underneath the surface
Mhm.
that may be bothering you that you're already dealing with. I said, but the knowledge that you gain, Dr. Khazem, and your team is going to be helping not just people within the Columbus area, but like you said, nationally, we have, like I said, over 1 million veterans struggling with post-traumatic stress disorder and TBI from the conflict recently alone, the global war on terror. So I find that to be really a service that get used to it now, because as we know with like chronic brain injury, it can be kind of a chronic illness.
Sure.
And as your brain changes as you get older, so do your coping mechanisms, so do the ability to cope. So I think to get on the groundwork would be very helpful. What types of disabilities, because I know you go a vast realm of that, do you see in your practice?
It is a vast realm. I typically see individuals who are struggling with mobility difficulties. I also see a lot of individuals with MS,
Oh, yeah.
blindness, low vision. Sometimes see folks with autism as well
I see.
as comorbid with other disabilities. But those are a lot of the main ones that I see. But certainly, it really runs the gamut.
So you deal both with people who kind of were born or genetically have disabilities and those who got them later in life,
Yes,
it
I
kind of
do.
comes on. I know that MS, MS really is one of those kind of neurodegenerative diseases that oftentimes strikes that young adult population,
Mhm.
and I do know of a couple of veterans who, after a major traumatic event, one young vet falling out of a helicopter,
Mhm.
kind of seemed to bring it on, the MS characteristics, and it was diagnosed. And I do believe that that population has a lot in common with our veterans because they have something that suddenly manifests,
Mhm.
and usually manifests to a degree that there's a disability related with it, or they wouldn't be
Mhm.
coming to you,
Right.
even if it's just the severe fatigue. So, coping for life is a very important thing, and realizing just as much what you can do as what you can't, So what is that? And do you approach it that way? Is that the right way for me to be approaching that? So many things. Let's focus today on what you can do, what you want to do, what you like to do.
Absolutely. I think there is a validity in grieving a life that is different than what
Yes,
we anticipated. And what are we going to do about it now?
I got you.
So, we want to develop lives worth living. What would that look like for you? That's what I talk to my patients about.
That's a very good phrase. Let's repeat that because I love that. Life worth living.
Yes.
What does that look like?
Hmm.
Oh, that's brilliant. That is really so wise for somebody as young as you are. Bless your heart. I,
Well, I didn't come up with that phrase. It's
but you use
from
it well.
Dr. Marshall Linehan, the developer of DBT,
Oh,
or
okay.
dialectical behavior therapy.
Okay.
But we do talk about building lives worth living or disabled lives worth living, even in the face of what society or our families even are throwing at us.
Yes.
So that's really the crux of a lot of what we do.
Right. And I think that so much it was Brigadier General Lori Sutton, the psychiatrist for the Army, that really began kind of defining the traumatic brain injury in the global war on terror. And she coined the phrase new normal.
Hmm.
This is what you need. And to your point, yes, there is a period of grieving. I went through an amazing one. If it weren't kind of for my Irish Catholic roots, I'm not so sure where I would have gone with it for sure. But it is really something that you have to come to grips with. And I've been asked many times, what do you think about this new brain of yours? And,
Hmm.
for the first 10 years, you would have asked, where's my old brain? I mean,
Hmm.
my old brain, I wouldn't have had to take notes for this.
Hmm.
You would have talked to me. We would have walked in here. I would have had it all. Or I could read it and remember it. And I could run into you 7 years later. I just thought that this new brain is not, You get a very long, drawn out sentence and I've got to dissect it. On the same point, I am much more empathetic
Hmm.
because I've been in that space, not for the same reason, but the result was the same in that space. And you can um, realize that there are things like I was saying as a doctor who had never experienced it. Oh, we're going to get you into therapy in 1 hour, 3 times a week. It's going to do it for no. No, it does not. It's that daily retraining the brain, retraining your body part. You really become, I call it a super athlete. You have to get the super athlete idea about it. I'm going to do this. And the thing with the brain, as opposed to other body parts, is it doesn't get better, doesn't get better, doesn't. And then suddenly all of the pathways kind of go down, the light goes on,
Mhm.
and you click. And I think that that's something very interesting with all of the different disabilities that you're seeing. You'll be able to kind of give that time frame, not that everybody should be the same, but to, you know, keep trying, see what this will do. Certain things, either that particular skill may come back to some extent, or you can do an end run around it. You're particularly with their younger brains, for sure. What advice would you give to our veterans out there who have so much loss? And let me give you one of my nightmare calls. And thank goodness, spoiler alert, it ended up okay. And this veteran is one of what I call is one of my little archangels who taught me so much along the way. It was Thanksgiving Day 2 years ago. And my phone rang, unknown number. Okay. I picked it up, and somebody on the other end of the line, very low and very slow, starts saying names to me. Okay. And I realized after about the fourth, fifth, I better get, where's my pen? Where's that? And I start writing down the names. Anyhow, 30 names total. And then he says, I understand you're a doctor dealing with veterans. I said, well, in a small space, yes, I am. He goes, those are 30 of my best friends that I lost during the war. 5 I lost in the war, 25 I lost from suicide when they returned. Now, that was a call that I sat there and said, wow. I did mention to him, I said, I'm like old enough to be your grandmother, maybe knocking on great grandma's door here. And I can think of 8 very close family members or friends, and you just gave me 30, and you're not yet 30.
Mhm.
So those are the kind of things that they're really facing, the grief that and loss, which is different than grief, I think. In a psychologist realm, is there a difference between grief and loss or the way you treat it? Because
Mhm.
I know people grieve somebody, but that feeling of loss just seems to be
Mhm.
deeper.
Mhm.
What is your opinion? Your expert opinion, because mine is not expert at
Mhm.
all.
I would say it's perfectly natural to grieve. And a lot of the people I work with in terms of loss, particularly lose their reasons for living. But
Oh,
I tell patients this,
okay.
and this is a quote from Dr. Craig Bryan, one of the
Oh,
creators
yes.
of VCBT, and I use this with patients quite a bit who, you know, have lost these reasons for living or don't see the reason to keep going. Sounds like maybe like the veteran who called you. Is Let me ask you this: have you ever lost your keys?
Oh, yes. And
Yes,
that makes me
yes,
crazy.
yes.
It does.
And what do you do when you lose your keys?
Oh, I'd really get very frustrated. And,
Sure.
again, the Irish Catholic in me comes out because St. Anthony, the patron saint
Mhm,
of all
mhm,
lost
mhm.
things,
Yes, yeah.
he becomes my new best friend, for the moment.
Mhm,
And I will tell you that there are times that I've lost him for up to 2 days.
mhm,
And it's so frustrating. I know that I should go calm down that, but I don't
mhm.
seem to do that very
And
well.
what do you do to try to find your keys?
Yeah, I try to retrace all of
Yeah.
my steps, go
Mhm.
back to where was I? What about the day before? Where was I? That sort of thing. Yeah.
Absolutely. But in that situation, the keys aren't lost forever. They didn't just
No,
disappear into a black hole and
correct.
vanish. We just have to retrace our steps to find them. It's similar with reasons for living when we lose them. They're not gone forever. They're just really difficult to find right now. So it's time for us to retrace our steps and figure out what they were.
Oh, that's a very good plan because we all need that. And I'll have to remember that next time I lose my keys because I do it quite frequently, I'll tell you.
Same,
I've
same.
got that key finder and I can't even hear it. They're so far away, I can't even hear where it may be. I don't have the pin yet. I'm not smart enough on my iPhone to know where the pin is and where they are, but that's really true. I would like to ask one other thing here and then I'll let you kind of wrap up for a bit because this has been, I mean, so informative for me and I kind of in this space. So for people that are just hearing for the first time, we really appreciate your calm, confident manner of how you can approach this. And I think we all kind of need to know that as well. Dr. Khazem, you have a great deal of experience with this already. what kind of treatments are available so people don't think, this is the way I am, this is the way
Mhm.
I'm always going to be?
So, when we think about suicide prevention, we do have great treatments available. So, the treatment that I train individuals on that has been supported in clinical trials, tested in veterans and military personnel,
Yes.
is called brief cognitive behavioral therapy for
Okay.
suicide prevention, or BCBT,
Okay.
because it's a mouthful, and it's one of the standard treatments we offer at S.T.R.I.V.E at Ohio State. It's about 12 sessions long,
Okay.
with about an hour or so per session.
Okay.
And we're also able to deliver it up to once a day, even to where people are finished with treatment in like 2 weeks.
Really. And
Hmm.
what sort of is that discussion therapy? Is that what sort of things are involved in that? Because
Sure.
I think there's people listening to who could benefit from that for sure.
Absolutely. The first part of our treatment involves learning skills to calm ourselves down when we're upset. Because when we're really upset, it's hard to even think straight. And it's hard to problem solve.
Right, like that loss of keys, it just
Right.
kind of keeps going. Yes.
Exactly. Or Thanksgiving dinner, right?
Yes.
So that's why we got to plan ahead, but it's like how to calm ourselves down. But we learn skills to calm down our emotions when we're upset, and also developing what we call a crisis response plan,
Uh,
that I know you were interested in
Right, for
learning more
sure.
about. And then after that, once people are able to calm themselves down, then we really tackle those beliefs that keep people stuck feeling suicidal over and over again. The thoughts that tend to pop up right before a
Okay.
suicidal crisis occurs or even during it. Like, I'm a burden. My life isn't worth
Yeah.
living. Things will never get better for me. We target those using series of skills.
Okay.
So that way, by the end of treatment, I tell my patients, I want to be out of a job. I want you to be able to be your own
Oh,
therapist
yeah.
and really target these beliefs on your own by asking series of questions to look at things from all sides.
I think that is so amazing. And thank you so much for explaining that because um, it's really interesting to me that so many of my veterans respond well when I say, well, you've had brain injuries and we need to take care of your
Mhm.
brain health. Versus if somebody uses the term, which is in the mental health, that you think it's all in my mind. I go, no, it's in your brain,
Mhm.
and that's what we're trying to do. So when you talk about like the cognitive behavioral therapy, you're actually retraining pathways in the brain to
Exactly.
respond with that. And I think
Correct.
that's very interesting. And 12 sessions is not that many,
Mm-mm.
to get somebody back on track.
It's not. People generally start feeling better way before 12 sessions, too.
Yes.
So we have lots of evidence from our various clinical trials indicating that it can work. There are certainly other therapies available as well, like dialectical behavioral therapy. If
What is
people,
that? Because that's a new one to me
that's
when you
another
just
one.
mentioned,
It's a
yes.
mouthful too,
Yes,
right?
it is. That
So
they all are.
they are. I know. Psychologists we like to hear ourselves talk. So it's called DBT for short,
Okay.
and it is a bit more intensive treatment, but also has a strong evidence base.
Okay.
It focuses on learning mostly behavioral skills to
Okay.
manage crises, to calm yourself down, to be more effective at communicating and building relationships with others, being more
Wow.
mindful.
Okay.
And it involves an hour a week with a therapist,
Okay.
one on one, and then a group therapy, which is for 2 hours.
Okay.
There are also phone coaching components as well, to where an individual can contact their therapist to help coach them through using skills in their daily life. So it's a bit more intensive and not necessarily as accessible, but some places will just offer the skills training components.
I really like that when you mentioned the phone. Technology
Mhm.
is something that the veterans from
Mhm.
the global war on terror really know. I mean, like I said, when I get stuck, I call one of
Mhm.
them to kind of help me through. And that really is that phone, that Android or iPhone is a lifeline. It
Mhm.
it literally is. And I love the fact that they can even do telehealth with that. And I
Mhm.
really do appreciate your bringing that up. Actually, we have an office, Resurrecting Lives, here in the Dublin, Ohio area,
Mhm.
but our secondary office is in San Diego. And I was actually able, with the help of Dr. Bryant, this was during the pandemic, like during heights in the pandemic, there was a whole block of veterans who were homeless in San Diego. And we were able to deliver his message via one guy held the iPhone here
Mhm.
and they could have kind of group therapy, that kind of thing. That is just amazing what you're able to do. And we so appreciate your being there. We appreciate the Ohio State being there. Dr. Fawn, who is your director, he's the program director. What is his official title? Because I'm not sure.
She's chair of the department.
That's it.
I think a few other fancy titles in there as well.
That he is really an amazing force of nature. I have a niece who actually interviewed. She's graduated from medical school in University of Texas, and is now going to be heading up the geriatric psychiatry program at Galveston. But I tried to get her to the Ohio State, and she absolutely loved all of the residents that she saw, and she absolutely loved Dr. Fawn. But the day that she interviewed, there was a snowstorm.
I was about to say Galveston is a bit warmer.
It's absolutely true. I couldn't believe it. It was the early November snowstorm that it was 22 degrees here, but with the wind chill, it was 0. And she had not been in anything below 75 for like 15 years. So that was the key. But I really appreciate everything that you're doing here. If you could leave our audience with parting thoughts or even a parting quote, I would wonder what that would be.
Sure. So I've talked about Dr. Marsha Linehan and her work. She has a quote that really sticks with me because there are a lot of interventions out there. A lot of people that I work with have been through lots of therapy. So I tell my patients this when they come in and they're hopeless and they said, Doc, I've tried everything. I say, some treatments or all treatments work, but some just save your life.
Oh, whoa. That is very, very true. Very true. And we know that not only is that person's life so valuable, but everybody's around him because of the possibility that suicide tends to oftentimes go in a cluster. So we do need to think that. So I really am so thankful for the Ohio State University, for Dr. Khazem, who, I cold call and said, I hear what you're doing. Would you be willing to share it with our audience? And that she would come and be part of the calm and the voice of reason in a holiday period, which can sometimes go beyond it. What I really do appreciate is any one of our veterans or veterans' families who are hearing this, or anyone hearing this who feels that they have an issue, please, go back and utilize some of those benefits at the Ohio State program. Sign up for that. Fill out the form online. And if it's a crisis, please do call your 988 number. Get in touch with somebody. Call a friend and make sure they stay with you, because you are so valuable. You get through this and you can drag other people with you back out of those trenches. So thank you all for being here, and the best of your holiday meal.
If you are thinking about harming yourself or attempting suicide, tell someone who can help right away. Call 911 for emergency services. Go to the nearest hospital emergency room. Call or text 988 to connect with the 988 Suicide and Crisis Lifeline. This podcast is made possible thanks to a grant from the Fred and June McMurray Foundation, and it's produced by the Resurrecting Lives Foundation at the Sycamore Studio. Music is written, performed, and graciously provided by Tim Beckley. Remember, when you work toward brain injury recovery, it is best to journey with a friend and keep your gait steady and your spirit strong. Finally, always seek shelter from your storm.
Baghdad, the Basra, the Boston, the Bakersfield. The hottest battle I ever fought is raging inside of me. My brain has been battered, scrambled and rattled, and no one knows what's going on.